Today's COVID update is brought to you by Fulltech Systems, your technology center, where you'll come for the price, but stay for the service.
And we're back.
And if you're joining us now, we're just getting our first conversations for this morning started. And as we said earlier, we are bringing you our COVID-19 update, and we're talking about some interesting new technology that will enable us to greater monitor lots of diseases. And joining us now, we have Dr. Kristy Murray, who is a lead investigator from AFI, that's Acute Febrile Illnesses, at Baylor College of Medicine. And we also have Dr. Gerhaldine Morasan, who is the director of the Medical Laboratory Service. And they're going to be talking to us all about this new partnership and this new technology. Good morning, ladies.
Good morning.
Good morning.
And thank you so much for joining us.
Thank you for inviting us.
Thank you. Thank you for having us.
Yes. Now, this is a really interesting topic, but before we get into the technology, perhaps Dr. Murray, you can talk to us a little bit about how this partnership came about and what the goals are.
Yeah, absolutely. So several years ago, we were given a funding opportunity to be able to look at different diseases across the country of Belize and try and monitor and track them. And in meeting with Ministry of Health, especially meeting with Dr. Morazan, we initially were thinking of just one hospital site at Carl Huesner. And then as we started thinking, why don't we just do this countrywide? And that was really Geraldine's idea to let's see what we can do and get creative with this so we can cover more people and be able to do a lot more for the country than just one particular hospital site. And so that's what we did. We expanded countrywide. So we have 11 different hospital sites throughout the country. If a person comes in with acute febrile illness, their samples are collected, sent to Central Medical Laboratory, to Dr. Morazan's, where she directs, and we're able to do all sorts of different diagnostics. So 52 different pathogens right now that we're looking for.
Yeah. So let's just break this down for a bit and talk about what you mean by acute febrile illness.
Sure.
Yeah.
Sure. So basically, anybody who's coming in with a fever, if they have a new fever that's developed in the past 7 days, then they're considered for inclusion in the study, and we collect samples from them. And one thing that was really nice is that this all launched a year ago, January, and in our first year, we've had around 1,200 people enroll. From January, of course, as you know, COVID emerged in March here in Belize, and we were able to very quickly expand our surveillance system to include COVID in that. Yeah. So having the technology in place allowed us to quickly adapt to new emerging pathogens, and that was the entire point of having this surveillance system in place.
So this surveillance initially was to look at finding out the different types of flu strains that we had in Belize, or just what we would have that was causing this type of illness?
So we're covering all sorts of different diseases, not just flu strains. Flu is part of it, but really our big part is looking at different arboviral diseases. So those are diseases that are spread by mosquitoes and spread by other insects as well. So dengue, of course, is one that's very familiar to Belize. Zika virus is one, chikungunya, Chagas disease. So all these different types of diseases that are spread by vectors. And then we're looking at a complete panel of respiratory pathogens, a complete panel of different gastrointestinal, so intestinal illness type pathogens, and it's really comprehensive. And what's really neat is the technology that we have in place. Say we're looking at a respiratory pathogen, there's 22 different ones that we can test for, and we get the result in 1 hour with one sample.
And Dr. Morasan, perhaps you can talk to us a little bit about how the Central Lab uses this information.
Yes, thank you, Kevin. Well, in the past, we needed to send our samples all the way to CARFA, and it would have taken almost two weeks to get the results. Now, with this technology and the partnership with Baylor College and CDC, we have in country the equipment, and we, like Dr. Murray explained, we have our results within an hour. Those results are entered in the BHIS system through the Ministry of Health. And then, so all the results will be received to the users or the doctors who are treating the patients in a very prompt, and they can respond quickly to treat the patients.
Yeah. And it's also, you know, let's backtrack a bit to what you mentioned earlier, Dr. Murray, when you said that it turned out to be a turn of luck for us here in Belize, that we were already monitoring acute febrile diseases or illnesses that was causing fever for people at the time when we started to face the pandemic. Can you explain how that ended up helping us?
Sure. So we had the technology in place to be able to do all these different types of diseases. And as soon as COVID emerged, we had the equipment here. We had the people trained to be able to do the type of work that needs to be done, the PCR testing. And then we were able to very quickly get the reagents that we needed as well. And all of this is really being supported by the CDC, the US government. And so when we talked to them and we said, hey, you know, this is something we need to now include in acute febrile illness surveillance, they're like, absolutely, let's do it. Yeah. And so they were able to provide additional funding for us to be able to include COVID in our testing.
And that made it possible for us to be able to test very quickly here at the time when people were still learning about the disease as well.
Right. And what was really nice is that we had already been doing surveillance for respiratory diseases. Yeah. And so we were actually even able to go back to January and test all those samples to see if the virus had even been here earlier. So by having had this system in place, it really allowed us to be retrospective and being able to see, has it already been here, you know, who's infected? And we actually did identify a couple of cases that way as well.
Interesting. So how early did you detect COVID-19 in Belize based on the samples you tested from January?
Yeah, our earliest samples in March.
Okay. Earlier in March?
Earlier in March, yes.
Okay. Oh, so it's still around the time that we had our first case detected too.
Right, right. And then what's nice now is that we're actually here, we're training again here in Belize. CDC provided and donated new equipment, and the new equipment is actually going to be able to allow us to look at antibodies to COVID. And so, you know, we have all these healthcare workers who have been potentially exposed, and now we're going to be able to look and see, do they have those antibodies to COVID? And so we were here training and setting up the equipment, and we had a very successful run yesterday with the first batch of samples. And so it's just, it's really nice to have this partnership in place.
Yeah. So Dr. Morazan, explain to us what the benefit is of being able to know the causes behind what you call the acute febrile illnesses.
Well, the benefits is that the doctors would get the result very quickly and they can treat the patients. But also, we will be finding out the respiratory panels that we will be sending all those results also to CDC. And these results, they get, they use them to guide us on what type of vaccine in the future we will need for Belize, meaning that they gather this information of the flu that is circulating in Belize, and they guide us on what type of flu vaccine they will use in the future for us. And so there is a lot of information that is being used, not only by the doctors to treat the patients right away, but also to guide us, to guide the Ministry of Health to when choosing vaccines. And this is also for the future in COVID, because thanks to the partnership, we were able to do the sequencing on the COVID-19. And then in the future, that will be probably will play a role on defining new vaccines in the future for us to see if it continues circulating in Belize, what serotype is circulating in Belize. So those are very important help that we will get. Yes.
Yeah. And so as you 1 year later, after you have collected data and seen some of, been able to know from the samples what you were seeing, how much of it became just all testing for COVID? Because we know that the flu was down since people were social distancing and practicing good hygiene.
Right. But we were able to pick up actually a lot of other diseases as well. We picked up 44 dengue cases over from starting in January going into April last year. We saw a lot of gastrointestinal diseases, so about 80% of samples that we collect from patients with diarrhea and vomiting, we're able to find a positive result for them. And so we've actually found a lot of different types of pathogens that are part of the gastrointestinal tract that most of them are treatable, which is really nice. Yeah. We identified a case of Chagas and like Gerhaldine, Dr. Morrison said, right now we're able to actually sequence too. So we're hoping to bring that next technology down to Belize, and so we can track all these different virus strains. Right now, having the partnership with Baylor College of Medicine, and I'm at Texas Children's Hospital, our pathology lab was able to quickly jump in and help out. So Belize sent us a lot of samples from their COVID positive patients, and we were able to go through and track and see what variants they are. And that's gonna be super important moving forward. As we have the vaccine now, we know the vaccine is effective for specific variants. We're concerned about new variants that could be introduced and whether or not the vaccine won't be as effective. And so we've got to keep a very close eye on those new variants and be able to very quickly identify if there's a new one that's here. So then that way we know what to do and can go in and control it before it starts to spread.
It took us quite a bit of time to be able to get the results on the testing for the variants. Can you explain to us what the process is and just how complex it is?
Oh yes, absolutely. It's actually, it's not a fast process at all. The samples were sent from Belize to Houston, and then we had them, we had to extract them and then run PCR, the ones that had really good numbers, send them over to our pathology lab. And it takes a good 2 weeks before we can get any kind of good sequence results. So it's not a fast process. We are working really hard to improve the timeliness of it. We're trying to get it down to where we can, over a 24-hour testing pattern, be able to actually get the first results. And as we're working through developing this technology, because remember, it's new to us as well in Texas and in the United States. And so we're all very quickly adapting to all these changes that are happening and trying to adapt the technology as well. And so what we're doing right now is developing the technology to bring here to Belize, so then that way it can be done quicker and it can be done easier and most importantly in a cost-effective way, because the sequences are about $500, $600 to generate each. And so we were able to get a very special deal through our hospital, and then our hope is to get it down to even under $100 a sample.
And so from it was 26 tests, I think, that Baylor had processed for us, and you found 2 cases of the UK variant. But what's interesting is that you also found another variant from the tests conducted in Belize. Tell us more about that.
Sure, we found 20A was the predominant variant going all the way back to March, which is the one that is the most common variant worldwide. Okay. Then we saw 4 cases of 20B, so very, very closely related to 20A, and that's what we've just been seeing naturally happen. Okay. That we're seeing these new strains emerge from that original strain. Versus the UK variant, which is completely different. We saw 2 of those that came in, and so having that data and that information was so valuable. We're now in the process of doing more. We have hundreds of samples that we're trying to go through and sequence. So we've so far run around 45 samples. So we're getting there. We're working as hard as we can.
And when you look at and this is a critical part of, as you mentioned earlier, as the vaccines are being rolled out at the same time, some of these very different variants or very unique variants are being detected. And so it's a matter of being able to ensure that these variants are, the vaccines are effective against these particular variants. So moving forward, it has to be a part of our continued surveillance. I believe you mentioned earlier that that's one of the things you are exploring on this visit, to be able to allow for us to do here in country. Is that what you said?
Exactly. That is our goal, and we're hoping to do it as quickly as we can. So we are already working with Dr. Morazan, looking at the space that we could potentially do this in. Actually, as we're speaking right now, back in Houston, my lab team is actually working on the technology, and we have everything that we need to be able to do it. So we're hoping that we get a successful run here by later today. And, you know, like I said, everything's happening in real time. Once we get it to work, then we're going to be able to bring it down here and train everybody on how to use the technology. So again, the technology isn't too terrible in terms of the equipment and other things, because of course getting equipment down here is always a bit of a challenge in a way. But what's nice is that it's just getting the reagents. It's really going to be the manpower. It's a lot of different steps to get those sequences, and so it's going to take a lot of training to do that.
Yeah. So you're going to train or lab technologists to be able to do it. That's the plan.
We have people actually hired under this cooperative agreement with the CDC to work in Central Medical Laboratory. So we actually have 4 people actually in Central Medical Laboratory working on acute febrile illness surveillance, and they are the ones we've trained now how to do the antibody testing. They do all the PCR testing, and then next we'll be training them on how to do the sequencing. Our goal is to bring the technology here and for the technology to be used and to train local Belizean lab technologists to be able to do the work.
And you know, just to be clear, and this won't the ability to test for these different or doing sequencing or different strains. It won't just apply, of course, to COVID-19, correct?
Correct, exactly. And that's what we're excited about, is that, you know, once we have this technology in place, we can adapt to other things. So it wouldn't be just sequencing for COVID. We could do sequencing for dengue. We could do sequencing for all these different pathogens. You know, like I said, we're looking at 52 different ones. And then especially what we are hoping to do is going back, looking when we have increases in different types of disease symptoms that we don't get a positive result on. So for instance, back in August and September, we saw an increase in the number of respiratory cases that were not COVID positive. They were not flu positive. We have 22 different pathogens we test for respiratory diseases. None of them were positive. And so by having the sequencing technology in place, we can go back and look at sequences and try and identify what those diseases are.
Are you only doing the study in Belize? What other countries are you working in? So
right now we're in Belize. Belize was our proof of concept, essentially. We knew here that we had incredible infrastructure, that we could put this in place and be able to bring the technology here. Belize is a nice sized country, so it's smaller. You have a population that's easier to work with, and now we're going to be moving this over to El Salvador and trying just a pilot study in one place there, and then see if we can expand it across the country in El Salvador as well. So we felt like Belize was the easier place to start, and it's been fantastic. I feel like what we've accomplished in the last year and a half has been unbelievable. When you say, Dr. Morazan, we have just just completely set up the system, and it's worked beautifully. And so having a success story like this one allows us to bring it into the next country.
Yeah. For you, Dr. Morazan?
Yes.
Uh-huh.
Yes, and it's also important to mention that with this study, we were able also to find co-infections that will be undetected if you're only testing for dengue specific, or if you're only testing for flu specifically. But here, because we have the technology and the project for the study was guided and planned that we will be testing all the patients with the acute febrile illness, not only with the respiratory panel, but also with the vector-borne diseases. So everybody gets to run those panels. So we have found that we have co-infections. Some people can be having a flu symptom and presenting a influenza, but at the same time, we found that they also were co-infected with dengue. So those things are very important for the clinical doctors to treat, because then they're fighting not only the influenza, but also they have to see, oh, okay, this person also is suffering with dengue, or Zika a lot of the patients were presenting with respiratory disease or pathogens, but we also found that they were having gastrointestinal diseases, and then we were able to target and found the pathogen that were affecting them.
Right, and I think too with what she said, the vector-borne diseases are really important because we work directly with Ministry of Health to be able to get in and control those vectors. And so if we do identify new cases of dengue or other diseases, then the vector control is very quickly activated and can go in and put in control measures. So getting rid of mosquitoes and other vectors. We actually did have one case of Chagas disease that was detected in a child that this case would have been completely missed. And Chagas disease is a parasite that can affect the heart. It's spread through what are called kissing bugs, these triatamine insects, and they take a blood meal, and then the person can become infected. And so by being able to identify that case, we were able to get in, and within 3 days, Ministry of Health had treatment in that child, which, prevented that child then from developing any kind of heart disease later down the road. Yeah. So, I think of these success stories, and, the way the child presented, I even looked at the case and I was like, I would have thought this was a dengue case based on the clinical symptoms. And, that's what typically is done in most countries, even in the United States, where we look at the way a person is presenting, we make our best guess as to what they have, but sometimes we don't exactly have the diagnostic tools ready in our hands to be able to do something about it. So with this, we've been able to say, wow, this child had Chagas disease. We need to get in there and treat this child, and looking at it, I don't think anybody would have ever suspected Chagas in this particular patient. So, having these types of ways to identify disease and knowing that we can actually do something then about the diseases is what this is all about.
And also the support that we got from Baylor, because after we identified this patient, vector control was alert. They went to do the inspection of the house. They did the fumigation of the house and everything. But we were also able to follow up on the patients and the family, and we were able to send the samples to Baylor to see if they were also affected.
That's interesting. And you also have another study that's ongoing, and I want to hear more about it. You mentioned that you're testing antibodies. So this will probably, I'm sure, help to feed into the global information about effectiveness of vaccines. Tell us a bit more about what you're doing.
Yeah, Dr. Morrison, would you like to talk about it?
I can start and you can finish.
Yeah.
So what we decided to do is that we wanted to test the seroprevalence on all the healthcare workers to see if they have been exposed. We know some of them have been, with the disease, they have been affected, but we don't know how many of the other ones were asymptomatic or they were exposed and then we didn't know. So we started to say we wanted to take samples before they take the vaccine and test them for antibodies. And then we will be having a baseline on knowing if they were affected or not. And then after the first shot of the vaccine, we will then collect a month after that, we will then collect another sample to test if they have a better or a good immune response and have created antibodies against the COVID-19. And so I know if you want to expand a little bit more, Kristy?
Yeah, so, I think what's really important about this is we want to make sure the healthcare workers are protected. They are the frontline people. They are the ones who are putting their lives at risk. We need to know that they're safe. And so as the vaccine is rolling out, having that baseline sample, one, tells us if they had the disease or not. Then we get the other sample, we can see, did they mount the antibodies that they need to protect themselves against disease? And so what's nice about knowing if they had it already before, when they get the vaccine, we can see, did it boost it even higher? Or, are they even having a stronger immune response than what they had before? And what's going to be important is that, tracking that immune response over time. When we have new variants come in, we know kind of what percentage of our population is protected. We're able to better understand protection. And then as they get another booster in, is there anybody who's not protected? Do we need to find a different vaccine for them to help them mount that immune response? So that is our overall goal, is to really show and prove that they have the protection they need.
Do we have any early indicators as yet to know whether or not you've found healthcare workers that showed that they did have COVID and probably never knew?
Right. So we have not looked at the data yet. We had our very first training yesterday on how to do the ELISAs. So the equipment had just arrived, and we got everything set up. And so we ran the first few plates yesterday. We definitely got positives because we're not too surprised by that. We knew there were a lot of healthcare workers affected by COVID. But we haven't had the chance yet to go back and look and see if they had symptoms or not, because we do have asymptomatic cases that occur. So, and one thing I want to bring up too with the acute febrile illness surveillance, we actually, because we also collect samples from patients who have gastrointestinal illness, and we have had patients who came in with only GI illness who ended up being COVID positive. So, you know, it's nice that we can look at the way COVID presents itself in so many different ways that we can, again, kind of expand and identify these cases to go in and control them.
So when will you begin the testing of healthcare workers? Because the rollout for the vaccinations for healthcare workers has already started. So many of them would have already at least received that first dose, or should have, I should say.
Yes, Marlene, we already did.
Yeah, okay.
We did collect the sample from them before they got the vaccine. So we collected 740, if I'm not mistaken. And yesterday we started to test them with the ELISA testing. So today we are gonna review the results, and I think we're gonna start collecting once there's a month. I know the first ones they started on March 4th. So by April 4th, they should have come with a month already. So we're going to start to ask them to send us the new samples so we can test them if they have developed the antibodies with the COVID vaccine.
Now, my limited knowledge, you know, let me ask: is it that you will see a difference in antibodies before and after? If someone takes a test before they get vaccinated and perhaps had been exposed to COVID, you do detect antibodies. Are you also monitoring how much more they have after that first vaccine?
Right. Sorry.
We're in science class. Go ahead, explain it to us. Yeah.
Go ahead. Do you want to explain, or do you want me to explain?
Go ahead.
Yeah, so we actually been doing this in Houston as well with people in our group who had COVID before and got vaccinated. And what's been really interesting is that when we look at their antibody response to COVID, their antibody response from natural infection is not strong at all. We even had one person who would have been susceptible to be reinfected again, and they had just had the disease back in June. So by looking at that, we were able to see, and then when they did get the vaccine, their antibody response was as high as a person who had already received that second dose of vaccine. So it provided a really nice booster to them. But it really was like, wow, you know, natural infection is not the way to build immunity. The way to build immunity is definitely vaccine. That immune response is so strong. It's really impressive.
And I mean, that's pretty interesting to hear. And I'm sure, because, no, I'm wondering if you could like go into that a little bit more about the resistance that's built with vaccination versus the natural immunity, because I think that's, yeah.
Right, this is going to be fantastic when we get the results, because it's going to give us proof that AstraZeneca or the vaccine that we are using, it worked, because it has we have the proof that it was we developed antibodies with the vaccine. So.
And we can see how strong those antibodies are, which is really nice. I can tell you from an eyeball test, yesterday we ran the first few plates, and I looked at one of the plates that had a good number of positives on it. There were some on there that were not a very strong, like we look at color, and then we put it into a reader and it gives us an actual number of what the antibody level looks like. And just from looking at it, you could see that some of the responses were not that strong. And so our hope is that when we get that next sample after vaccination, that we see it just really boost up and really be a strong protection for them.
This sounds like, you know, I'm trying to imagine the information that you're going to get from this. So first we'll find out who had COVID and didn't know, the people who perhaps were asymptomatic or never got tested to know they had COVID. And then you also find out what level of antibodies they developed from having COVID, and then seeing the difference after the first shot. Will you also test after the second shot?
Yes.
Yeah.
Yeah, what we're planning on following this set of samples or a set of persons. We'll try to follow them after a month of the first vaccine, after a month of the second vaccine, and then we'll do 6 months after that, and then 6 months after that to see, and then we will determine. That information will be helpful for the Ministry of Health to see when we need the next vaccine, if it's going to be seasonal, if it's going to be every year, every 2 years.
Okay.
So that is the information that we are going to gather after that.
And yes, and we're also going to be monitoring whether or not they get sick. So seeing that they have the strong response, monitoring that immune response over time to make sure that they're protected. But if they do get sick and we do find that they have COVID, then we need to know that. Yeah. And so it's a way for us to also have just a monitoring system in place to let us know that the vaccine is doing what it's supposed to do, which we feel very strongly about the effectiveness of the vaccine. But having real world data from Belize, and especially as we're doing this, knowing what sequences are happening here locally, is all of that as a big picture perspective is going to really give us incredible data to control this virus.
And Dr. Murray, before we start to wrap things up, I think one of the critical points to look at is the level of human resources we do have in Belize. I know very often we think of ourselves as a small country, but what the Central Medical Lab has been able to do over the past year is something that really goes unrecognized. Talk to us about that partnership and what you've seen coming in and working with the team there.
Oh my gosh, I can't tell you how much I love this partnership. It's been just a great, wonderful working relationship. I came out here in late November when you guys were all having your surge, and it was just really severe here, and lots and lots of cases starting in November going into December, and we were actually able to come and help expand one of the machines and get another machine online, so then that way you guys could increase the number of testing that you were able to do, and so I got to see for myself the number of people in there working. I mean, truly day and night, 24 hours a day, processing all of those samples and getting them run. And I mean, it was very overwhelming. And you know, I've seen this ourselves in Houston. We know exactly what this is like. And just seeing them in there working so hard and just really putting in all their effort to get these samples tested. And it was really nice to see. And so, yes, you know, laboratory workers to me are the ones we never see, but we rely on so much to give us, you know, everything that we need to be able to treat patients and to be able to help save lives. And so it's really impressive to see it. And you have a strong workforce here. And again, having the technology in place, we train and then they train and we expand the knowledge.
Mm-hmm. All right, well, that's good to hear.
Yes, and the persons were very receptive. All the laboratory technologists that were all, we moved people from microbiology unit to the molecular biology, and they were quick to learn, and they you know, cross-train each other, and they were very fast on learners, and then everybody pick up on how to do this new technology and the testing.
All right, so let's just, as we wrap timelines, we know the acute febrile illness surveillance is ongoing, and you're collecting data there. You're also doing the antibody tests, and you're working to prepare for sequencing, right? Right. And what's the timeline for us to be able to get to the point where we're doing our own sequencing to know the variants that we have here?
It's a great question. $1 million question.
Literally.
Yes, literally $1 million question. So we right now, of course, are still processing samples in Houston too, and continuing to run them there through our hospital laboratory. So our hope is that after this run, we feel that it'll be successful. We've brought in a lot of different people to help with the technology. our goal with this was to get it as inexpensive as humanly possible because we want to be able to run as many as possible. And so we're hoping that by this next week, we will show that we have a successful run. We'll be excited about it. And then our next trip down will be to bring it and train everybody.
Yes, and we also are going to be working closely with CDC, preparing a protocol and deciding who will be sequencing. We're not going to be sequencing all the samples, but we need to find out work on a protocol and decide who gets what sample gets sequenced.
Okay. Well, Dr. Murray and Dr. Morazan, we are just about out of time. So we want to say thank you again for coming in and sharing all of this knowledge about the new technology and the ways in which it will benefit us. So, thank you so much for coming in this morning.
Thank you. Thank you for the invitation.
Thank you for having us. Have a good day.
All right. You have a great day as well. And with that, we are now going to be taking a break. And when we come back, we're going to be shifting gears and talking a bit about forest conservation. So please stay tuned and we'll be right back after the break.
This COVID update was brought to you by Fulltech Systems, your technology center, where you'll come for the price, but stay for the service.